Good morning, distinguished speakers, moderators, and participants. Welcome back to the second day of the fourth UNJAYA International Conference on Health Sciences. I wanted to deliver about announcement rules. Before we begin, please ensure that you are rename your Zoom ID with your full name and institution. Use the official virtual background of UNICHS 2025 and kindly fill in the attendance form through the link shared in the chat box. Also, please stay connected as we will begin shortly.
Recording in progress.
Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. And a very good morning to everyone. Ladies and gentlemen, welcome to the second day of the 4th UNJAYA International Conference on Health Science. We truly appreciate your continued participation and enthusiasm in this academic gathering. To begin today's session, allow me to briefly outline our schedule. We will start with the poster presentation, followed by 2 scientific sessions, oral presentation, and finally the closing ceremony. Let's start the day with the energy and curiosity. We will start today with the poster presentation part 2. Please enjoy and observe the ideas and innovations shared by our presenters.
Welcome back to the poster competition session of the UNJAYA International Conference of Health Science 2025. In this second part, we continue to present outstanding poster from participants whose research reflect innovation, integrity, and a strong commitment to advancing healthcare through science and education. Let's move on to our next presentations. The relationship between social support and student preparedness in facing disaster at SMAN 1 Kalasan by Era Rosalina and Novita Nirmalasari from Universitas Jenderal Ahmad Yani, Yogyakarta. A comparative study of stigma between health and non-health students toward people living with HIV/AIDS in Yogyakarta by Kakak Abdurrahman Karim Amrullah and Dwi Kartika Rukmi from Universitas Jenderal Ahmad Yani, Yogyakarta. The effect of past booklet-based education on the personal safety skill of school-age children nursing department, Stikes Surya Global, by Latifa Susilowati, Duyati, and Suryati from Universitas Jenderal Ahmad Yani, Yogyakarta and Stikes Surya Global. The correlation between motivation and the readiness of nursing students in first aid for traffic accident victim at Jenderal Ahmad Yani University, Yogyakarta by Fani Puspitasari and Novita Nirmalasari from Universitas Jenderal Ahmad Yani, Yogyakarta. The correlation between attitude and preparedness in dealing with earthquake and tsunami disaster among students of SMP Negeri 2 Kretek by Tricia Irmayanti and Novita Nirmalasari from Universitas Jenderal Ahmad Yani, Yogyakarta. The relationship between stress level, sleep quality, and blood pressure in elderly patient with hypertension at the Elderly Posyandu Kadirojo Kalasan by Rizkiana Andika and Ferianto from Universitas Jenderal Ahmad Yani, Yogyakarta. Factors influencing women's belief about childbirth during pregnancy, a cross-sectional study by Susanti, Sylvia Moana, and Ana Faiza from Universitas Batam. The aromatic foot bath hydrotherapy for managing sleep disorder in elderly by Rizky Wahyu Hidayati, Anastasia Suci Sukmawati, and Yuli Asuti from Universitas Jenderal Ahmad Yani, Yogyakarta. Utilization of complementary and alternative medicine and its associated factor among men who have sex with men living with HIV and antiretroviral in Yogyakarta, a cross-sectional study by Dwi Kartika Rukmi, Zidan Setiawan, and Tan Chun Ho from Universitas Jenderal Ahmad Yani, Yogyakarta and Lincoln University College. Nurse as a crucial part in disaster response, a systematic review by Pusparini A. Ayuningtyas, Desi Listianingrum, Novia Faizati Wahida, Suprayogi, Rafia Rukhana, Purnomo Wahyudi, EKS Rianto, Hari Setiobudi, Syahirul Alim, Sutono from Universitas Jenderal Ahmad Yani Yogyakarta, Universitas Jember, Politeknik Negeri Subang, Universitas Alma-Ata, RSUD Dr. Sudirman Kebumen, RSUD Dr. Muwardi Surakarta, and Universitas Gajah Mada. This marked the end of the second segment of our poster presentation. We truly appreciate the dedication of every researcher who have contributed to this competition. Stay tuned, we will soon process to the final part of the poster exhibition. See you in...
So now we will process to our scientific session of the day. To lead this session, I'm pleased to introduce our moderator. He is a lecturer at the Nursing Department, Faculty of Health Sciences, Universitas Jenderal Ahmad Yani, Yogyakarta, and currently serves as the head of Cooperation Division. Mr. Suwarno obtained his Master Nursing Science degree from Khon Kaen University, Thailand, under the international programs. He has extensive experience in teaching, research, and community service, particularly in the areas of family health nursing, community empowerment, and innovation in stunting prevention. He has presented his work at various international conferences, and he is actively involved as a reviewer and presenter in national and international academic forums. And now, please welcome Mr. Suwarno, Master of Nursing Science.
Hello and good morning, everyone. How are you today? I hope you are doing well and will stay with us until the end of today's conference. And thank you to our Master of Ceremony today, Miss Lola. I'm Suwarno, but you can call me Ano, and I will be your moderator for today's conference. Ladies and gentlemen, today marks the second day of the fourth UNICS hosted by Nursing Department, Faculty of Health, Universitas Jenderal Ahmad Yani Yogyakarta, or UNJAYA. And what a great moment to be together in this prestigious conference with our two outstanding speakers from Boro Marajonani College of Nursing, Khon Kaen, Thailand, and also from Faculty of Health, Universitas Jenderal Ahmad Yani Yogyakarta. Our first speaker is Dr. Tiparat Utmuangpia, PhD, Master of Science, Registered Nursing from Boro Marajonani College of Nursing, Khon Kaen, Thailand. Hello, good morning, Achan Tiparat.
Good morning, Dr. Eno and everyone. I'm happy to be here. Thank you.
Okay, thank you very much to joining with us today, Achan Tiparat. Okay, I would like to introduce Dr. Tiparat Utmuangpia for all the participants in here. Dr. Tiparat Utmuangpia is a Thai nurse educator and researcher at Boro Marajonani College of Nursing, Khon Kaen, Thailand, under the Boro Marajanok Institute, Thailand. She holds a PhD in nursing and health innovation from the University of Missouri, USA. 2019, and also Master of Science in Caring Science from Mälardalen University, Sweden, and a Bachelor Science in Nursing from Boro Marajonani College of Nursing, Khon Kaen. Her research focuses on intimate partner violence, or IPV, healthcare responses, and adolescent pregnancy, with a strong emphasis on cultural adaptation and health innovation. She has served as principal investigator for several funded projects, including the NIH for Gertie International Center K43 Emerging Global Leader Award for developing My Plan Thailand to support IPV survivor. Dr. Tiparat Utmuangpia has published extensively in international journals, presented at global conferences, and received multiple awards for research excellence. Dr. Tiparat will share her knowledge and experience on intimate partner violence or IPV during pregnancy today. During her presentation, participants might type your question in the chat box, or you can raise your hand using the Zoom features. Dr. Tiparat, are you ready?
Yes, I'm ready. Thank you so much, Dr. Eno, for the introduction.
Yeah, I'm fine. Okay, the floor is yours, Dr. Tiparat.
Thank you. So I have time until 10, right? Sure that. Okay. So thank you so much again, Dr. Eno. If I speak longer, just feel free to let me know this time out. So again, I am Tiparat Woodmungpia. So today I would like to share about the intimate partner violence during pregnancy. That is the issue that is still behind from the health sciences and midwifery across the world, not only from Thailand, Indonesia, but the world for that. So let me talk a little bit about Borough Rajashani College of Nursing. You know that we are from Thailand and we have the MOA with your university. So these are our university. It's called Prabarom Rajanok Institute. That our vision is for the world-class university for primary care. And we have 30 nursing colleges across the country. Borough Rajashani College of Khon Kaen is the one of that. This is our nursing college. So we welcome you to visit us and to have collaborations in academic and research and exchange cultural anything. Yeah. So let's talk about the intimate partner violence. So you as no as domestic violence or any violence for that, but intimate partner violence is for partner violence, right? So it's defined as a physical, psychological, or sexual violence. So you can see the statistic from that. You can see for this the global prevalence that 1 in 3 women who have experienced with their lifetime, the lifetime, 1 in 3, right? That's so high that, and you can see the Southeast Asia. The Southeast Asia would be 37.7. 37.7 is the highest one for that. Yeah, I can tell that is the highest more than chronic disease and non-communicable disease like hypertension, diabetes mellitus, and kind of thing. But it's still ignoring from the healthcare sectors for that, because they thought it would be the social things, but also the health sector things as well. So, okay, this at the global one, right? For Thailand, this is the statistic one. The Thailand is about you can see the circles, the size of circle. In Thailand, you can see the 44. It would be 44% of women who have experienced abuse, physically and or sexually abused. 44% of women, and 22% that 22 within 44, they have experience in their life within a year. Within a year, it means that they still have experience abuse, right? 1 in 5, they still have experience, but almost 50% they have experience in their lifetime. Yeah, it's a lot. Let me see Indonesia for that. Indonesia. Wow, I haven't seen Indonesia here. Yeah, but still have the problem on that. You can see it's not just only Vietnam and Thailand, but across the world, across the country. So let's talk a little bit about power and control. That if we talk about violence, and also in low and middle income countries or developing countries like us, that violence usually from power and control. About that, we have the cultural things that a man would be a superhero in family. Women have to stay at home to take care of children, kind of thing. So when we talk about violence, it's not just only physical violence, right? People, you say like, oh, I have to have injuries. I have to have arm broken and leg broken and kind of thing. But no, not exactly. So you can see that there are many forms for that. Physical violence, right? Physical violence, using coercion and threats as well, and intimidation, emotional abuse, like putting her down, making her feel bad about herself as well, using isolation, that controlling what she does, who she sees and talks to, right? Using children, right? Like making her feel guilty about the children, using the children to relay messages, using visitations to harass her, and using male privilege to treating her like a servant, making all these big decisions, right? And economic abuse as well, preventing her from getting or keeping a job, making her ask for money, giving her an allowance, kind of thing. So these are the intimate partner violence forms, right? So let's talk about a little bit from the World Health Organization, that they have the pathway and health effects on that. So like I said before, that it's not just only social problems, but also health problems, right? So it have some like physical trauma, right? So physical trauma for sure. And also psychological trauma, stress as well. So for sure, like mental health. Twice, right? Twice as likely to experience depressions. Survivors, intimate partner or violence survivors have twice experienced depression, right? And fear and control, that they have limited sexual and reproductive control, right? For that, they're not allowed to have contraception for that. And and they have twice as likely to have an abortion. And for the control, that the healthcare seeking, that lack of autonomy and difficulty seeking care and other services. So like my research experiences about that, it seemed like the Muslim culture, you guys have been teaching like have to have a good relationship together, I think that's good one for that, right? Have the relationship between have the good relationship between husband and wife. That would be nice too. So, however, that like I said, that violence it happens across the world, right? Everyone can have experience of abuse. But let's talk about cycle of violence. So, why we have to know about this? Because you guys are healthcare providers. You are the front keeper to see the patients, right? So you will see like oh, I think last month she told me that she has experienced abuse. Her husband just hit her, but for this month that she came to the hospital, she feel good. She feels like nothing happened. So that's why that you have to know about the cycle of violence. So the cycle of violence is like when you start having the relationship together, it would be the honeymoon phase, right? Honeymoon state for that. Everything is good, right? And also, the years would pass so quick that would have the tension building, right? Cannot talk comfortably. Yeah. So it's called tension building. And everything, after that, it would have violence that, would talk like loudly, would, and make make people feel down. And then they would have like a hit or shock or kind of thing. It would be started from that. It's called violence phase. And if violence phase, that the husband would feel like, oh, I'm so sorry to do that. Please give me apologize and please accept my apologies for that. I'm so sad. I would not do that again. So, and then the women would feel like, oh, I'm okay. I would like to give you another chance for that. So it would have the honeymoon state again. And it also would be the tension building state again and violence again. So this is the cycle of violence that you guys should know about that. Because when you screen women and ask women about this, even though if women just talk to you like, oh, I'm okay, I'm good. But the next time they would tell you like, oh, I'm sorry that my husband just hit me and kind of thing. And yeah, I mean, it's changed as a cycle that you need to ask women in every visit. And WHO, they recommend that universal screening for asking women about violence. It should be in women department, for example, like for antenatal clinic, for gynecological clinic as well. And also women, they have signs and symptoms about that. So talk a little bit about that. These are the statistics from the World Health Organization. They said that 70% globally have experienced sexual violence for that. For the globally, right? For the high income country like HIC have almost 13%, right? For the for us, LMIC, we have about 5%. So this is the reported from the World Health Organization in 2010. So it would be higher, I guess. And this number, it would be underreported for sure, especially in low and middle income countries culture that it seems like it's not common to talk about sexual violence, right? But it happens. Yeah, let's talk about the violence group. The years, the range of years for that. So this is the number from the World Health Organization. They would have 15 to 19 years old that they have reported. You can see, right? It would be 29.4% for that. So it's from your student and from my students as well. It is the adolescent groups that we ignore for that. And is it from your students, my student ages to 20 to 24 years, it would be 31.6. The most number would be 40 to 44 years old. That would be 37.8. So it would be basically 1 in 3, right? Yep. So let's talk a little bit about Thailand. So yeah, 15% of respondents experience psychological, physical, and or sexual violence in their lifetime in past 12 months. So you would remember the last number that I showed you, this one. So it would be 44 and 22, right? And this one, so this is the research in 2018, we found about 15%. So it depends on the locations, the places that you ask, the number would be different, right? So this they asked in Bangkok. So it would be underreported for sure. But you can see like 15% of experience physical, psychological, and or sexual abuse. But for the psychological violence was the most common for that, about 60 to 68%. That is a lot, right? And sexual violence occur in 62 to 63%. That is surprising that, right? Because the last slides that we talked, sexual violence is seem sensitive and the lowest number for low and middle income countries, right? But this one is seem a lot for that. Yeah. So I can tell that today is talking about midwifery. Why I mentioned about IPV? IPV is mean intimate partner violence during pregnancy. So is high levels of violence during pregnancy, but people ignore to ask about it because we perceive that during pregnancy, pregnancy women, it seems like the priority and special women that people have special care from family, from everything, from workplace and kind of thing. But well, it would be okay to perceive about that. But some pregnant women, they have experienced violence during pregnancy. So this is shown from the World Health Organization global issue. So let's talk a little bit about reproductive coercion, right? So reproductive coercion and pregnancy coercion is mean like telling her not use birth control, forcing or pressing into pregnancy, physically hurting her if she doesn't get pregnant, right? So so you guys are Muslim and would be telling her not use birth control, it would not apply for that. But forcing or pressuring into pregnancy, physically hurting her if she doesn't get pregnant, that can apply for that too. For the birth control sabotage, intentionally breaking or removing condoms, taking away her contraception for sex without a condom. So this is the things that midwifery providers have to think about and have to perceive that is happening, right? And IPV during pregnancy, why I talk about this? IPV during pregnancy is increase the risk for maternal complications. Increase the risk of emergency cesarean section, increase the risk of preeclampsia, prematurity, and adverse fetal outcomes. And I just review the paper that during pregnancy with violence, it can increase the risk of diabetes mellitus and non-communicable disease as well. That's very interesting, right? Fetal exposure to IPV-related stress, right, may lead to a long-term neurodevelopmental and mental health challenges for sure. Unplanned pregnancies linked to reproductive coercion are associated with higher IPV risk. Yeah, these are very important things that we found from the papers, the articles, that more than 50% of women who have unwanted pregnancy, they have experienced abuse and they have experienced reproductive coercion for that. Yeah, right. I think these are remarkable things and remarkable knowledge that midwifery should know about that. Yeah, and also IPV is associated with adolescent pregnancy, unintended pregnancy, and would be 2.5 to 4 times the odds women of unintended pregnancy. Yeah, pregnancy is not a protected term that I talked to you before. Like, if you are women, you're free for violence. No, it's not like that. If you get pregnant, you have to have the chance, the opportunities to get violence as well, right? Yeah, the strongest predictors of IPV during pregnancy, it can be strongest predictor that they would have experience of IPV before pregnancy, and also have the stronger predictor will have experience about IPV after pregnancy. I mean like IPV, after pregnancy, during the postpartum stage for that, right? So that's why midwifery people, the midwives, have to screen women, have to ask women about violence, because it would have the risk of abortion, the risk of miscarriage, the risk of low birth weight and preterm birth as well, and mental health as well, for sure. So you guys would have asked me and have some things on your mind that, Ajahn Tiparat, why IPV during pregnancy, right? What is explain for that? Yeah, could you please explain for that? Why is it happen during pregnancy? So I can tell that I don't know why. It seems doesn't make sense for that. But this is theoretical expectations to describe for that. So it would be seriously, baby is an competitor, right? That's you yeah, it seems doesn't make sense, but it happens. Attention of others. So women would pay attention to the baby and they forgot their husband, kind of, right? Sexual jealousy. They have fantasies of infidelity, right? And 2 times abdominal injuries in pregnancy, right? You can see, right? 2 times abdominal injuries in pregnancy. That doesn't make sense, right? What do women tell us? All of the above, but primarily business as usual, unrelated to pregnancy, right? Power and control for that. Yeah. So pregnancy issues associated with IPV, right? About miscarriage, about poor maternal weight gain, anemia, bleeding, abruption, chorioamnionitis, HIV, vaginal infections for sure, depression, anxiety, maternal smoking and other substance abuse, and preterm birth and low birth rate. Preterm birth and low birth rate, it would be 1.5 to 3 times when compared without IPV, right? And infant mortality for sure. So I have been interested in this area and have been doing the research for that. Yeah, for sure, these risks are associated for pregnant women in Thailand as well. So let's talk about a little bit IPV pregnancy in Thailand. So this is the study. In Thailand, we have 475 pregnant Thai women. We found that 13% ever abuse and 5% physical abuse during pregnancy. 5%. Even though you told like 5% is small number, but exactly it's not small, right? Because pregnant women, we try in Thailand, we try to encourage women to get pregnant, right? But to get pregnant with good quality of life during the pregnancy, this one is preventing about the good one, right? Thai women abused during pregnancy were more likely to be younger, unmarried, low income, unemployed, right? This is the interesting information. And have an unwanted pregnancy and have less positive health practice, more depressions. So our our results, it is aligned with the international results as well. I haven't seen much about the publications about IPV during pregnancy in Indonesia. Yeah, it means that it still need to do that, to do research about that as well. Yeah, for the risk factor for IPV, well, you guys already know that the young age, right, and low socioeconomic status. This is the risk factors, but it doesn't mean that everyone who have low socioeconomic status and low income, they would have that. Because we know that, and we are pretty sure that every woman, not only poor women, but also rich women, and not only low level of education, but also high level education. They still have the chance to get balance as well, right? And it's a very, very crazy and the high risk in Thailand about substance abuse, because we have critical problem with this. And substance abuse would be the increase the risk of risk-taking behaviors and make the imbalance more severe, right? Yeah, that I talked before, the mental health impacts, depression, anxiety, and PTSD. So, yep, let me do that. Let me, skip a little bit and when I see the time for that. So, okay. You guys would think about that. Okay, Ajahn Tiparat, you talk about screening and asking about women. So do you have the tools for that? Yeah, I do have tools for sure. And I do have research, but using the tools on that. However, so you would see that you would have some perceptions that Ajahn Tiparat, that if I ask pregnant women about violence, are they talk to me back? Are they would think that it's comfortable to talk? It's comfortable to tell about that? Yeah, this is these are our perceptions about, that from the healthcare providers. But the study and the report that I did in Thailand, that if you ask women, like a pregnant women, about this, they said that, yeah, if healthcare providers ask me, I would be happy to share and to talk about that if I have that experience, right? So it means that they trust you a lot. They thought that if you ask them, you would have some ways to help them. You would have the resources to help them for that. So they would not like look at you like, oh, that's, it's not polite for that. It's not like that, right? So this is the abuse screening tool for pregnant women. There are many tools for that, but about the abuse assessment screen tool is called AAS. It seems like it seems aligned for pregnant women for that. So let's talk like
Tiparat,
yeah.
Your time,
Yes.
15 minutes left.
Thank you so much, Dr. Eno.
Yeah,
That would be
welcome.
very helpful. Thank you. Thank you. And you hear me clearly, right? Okay, thank you. So you can ask like in the last year, have you been hit, slapped, kicked, or choked, or otherwise physically hurt by someone? For the first question. The second question is, within the last year, has anyone made you do something sexual that you didn't want to do? The third one is, are you afraid of your partner or anyone else? And there are 5 questions that, since you've been pregnant, have you been hit, slapped, kicked, or otherwise physically hurt by someone, right? This is the pregnant, right? And since you have been pregnant, has anyone made you do something sexual that you didn't want to do. If they just, so they have to answer like a yes or no. If you say yes, at least one, she has been, taking risk for ovarian during pregnancy. This is the screening tool. If we say yes for one, at least one, you have to assess more and ask more for that, right? Mhm. Yeah, so, okay. And then, for example, that if I ask you guys, so do you have experience in the last year about your partner just choke you, fixing you, and kind of thing? So she said that, yes, I have that experience. And the things that midwifery should talk about and kind of like validate her, because she would feel and think that it's my fault. It's my fault. I'm so sorry. This is my fault. She just blame herself for that, right? But you can validate her that, thank you so much for sharing this with me. No one deserves to be treated like that. It's not your fault. You are not alone. You're with me. Let's talk about what the ways I can help you for that, right? So this is the thing that the midwifery should respond and validate the survivors about. What if she doesn't want help? So you would see like the situations that, I'm okay, I don't want you to help, but I just share about this experience to her. That's okay, right? That's okay. Just support her and tell her that, help her address health concerns, that tell her that, okay, I know that you don't want us to help, but let she know that there are some risks during pregnancy. With violence, that she have to be aware and concerned, for example, about depressions, about could not sleep, about stress, and also about abortion and low birth rate and preterm birth as well. So help her to address the concern and support her choices, even if you disagree. So for example, that if you disagree that, no, you should go with us, we would like to help you for that. No, don't say it like that. Don't disagree with her. Just support that. Okay, I support her choice right now. I support your choice, but let's talk a little bit about how to make you to be safe for that. So be there for her no matter what, and keep your door open. Let her know that you are here. You are here to help for that, right? So this is the research that we have done, and this is the adaptation of the screening tool that I have been doing the research in Thailand for asking women, pregnant women about that. And so this is my research that about prevalence of IPV during pregnancy and associated health outcomes among Thai women, Thai pregnant women. So I conduct with 470 pregnant women and screen for 340 eligible for study. And we found that we have physical abuse for 7.1%, emotional abuse for 47.4%, and sexual abuse for 8.2%. So we found that women with pregnancy have complications, had significantly higher IPV severity score. It means that women experience, you have the pregnancy complications such as GDM, such as hypertension, have had significantly higher IPV severity score between 11 and 10.4 score for that. And women who have experienced stress in the last 2 weeks had significantly higher IPV severity score. Right. These are interesting research that we found out. So these are the papers and that I found it from IPV during after pregnancy is a postpartum period in Vietnam and also in Malaysia as well. That can see that our Southeast Asian countries we still have been facing about IPV for women, right? So these are the roles of healthcare providers, right? That I hope that I would tell you about more details about that. But this is the LIPS approach that is applying for healthcare providers that the World Health Organization recommended you should respond that. LIPS approach is like a L like a listening, I inquiry, and we validate, and E enhance safety. So I don't have time to talk about the details. You can see more from the paper from WHO, but it's a very good one. And we have been doing research in training healthcare providers by using the RIPS approach for that. If Indonesian providers would be interested, we would love to share more about that. Yep. Yeah, this is the, our research that we have been training about that. Yeah, can see more. And yeah, what are things that you would like, okay, Ajahn Tiparaj, what the healthcare providers should do, right? What we should do for that. So the things that from the research, they would have significant things that talk about safety planning together, make sure that your survivors, burden survivors to be safe and support the choice with them. Even they choose like I would like to stay with partner, that would be okay. But if they choose like I would like to live from their partner, that would be okay too. Just talk to them, talk together, and find the safety plans together. This is the one that we recommend for the research. And also, I have been adapting the app for Thailand about we call the VSafe app that I got a grant from the US to do that. Yeah, I hope that would be like the next time that we can talk about the applications that we have been adapting for Thailand for preventing violence for that. There's the details, and you can see more from my slides about that as well. Yeah, I think I should finish. And yeah, thank you so much for listening and for having me here for that. Thank you. Yeah,
Hi.
Dr. Eno. Yeah, sorry. Yeah.
Yeah, thank you very much for your explanation, Ajahn Tiparat, about intimate partner violence during pregnancy. It is very nice presentation, Ajahn, because we know about the IPV in women, for example, in Thailand. So now we will have a Q&A sessions which will last about 15 minutes. To the audience, if you have any questions, please type them in the chat box or raise your hand using the Zoom features. Is there any question in the Zoom meeting? No?
I just
Okay,
see,
okay,
yeah,
maybe,
I just see from the
yeah.
chat board, right?
Okay, maybe the committee can solve the question.
Yeah, I see from the chat that, sorry, that questions for Mr. Bharat, how is the strategy for preventing violence, the pregnancy? It is excellent question. What are the impacts of the pregnancy and their baby if they have experienced violence, right? So it is. I love these questions for sure. The strategies for preventing violence, the pregnancy. You may have a lot of strategy for sure. I think the first one that educating people and make pregnant women have literacy about what is the forms of violence, how they recognize about toxic relationship, how they know about healthy relationship for that, right? And when I finished my PhD from the US, I would say like, oh, I would like to change the culture about this, but I'm wrong. That it would make years to change the perceptions of that, right? So I can tell that educating people and screening and make them like recognize about the size of violence and the impacts of pregnancy. So like I said before, like abortion, preterm birth, and low birth weight for that, and mental health for sure, for depressions and stress, and also attempted suicide as well.
Okay, thank you, Achanti Prat, for your answer. And the second question is, in Thailand, where do victims of violence report incidents? What is the process? In Indonesia, there may be many cases of IPV, but victims may be afraid or ashamed to report them.
Wow, I love this. Yeah, exactly. I can tell in Thailand it's the same. Same, I can tell. Even though we have the hotlines, right? The central hotlines is 1300. This is the central hotline for violence. However, we do have the one-stop crisis center in our hospital in Thailand. So we have the fast track for women to go there and to report that if you want, I mean, to inform the providers if you want. However, we still have we still have the same problem that for my study, just only 10% of women who have informed to formal resources, right? It's called formal resources. But 90%, they feel ashamed, they feel stigma. They just talk to their friends, their families about that. So that's why my application, I would like to educate their friends and their family who talk to survivors about that. Yeah.
All right, Achan. Based on your explanation before that you have application, and then could you explain a little bit about your application that you developed?
Yeah, thank you so much. Thank you. So like I said that I could not reach out to 10%, right? To 90%, right? Just only 10% just walk in and talk to us, talk to providers about that. but 90% I could not reach out to that. So my application would like to educate friends and family and correctly about safety plans, about LEAP's approach, educate them that you have to listen, you have to talk to them and kind of thing. So about my plan, okay, let me show a little bit for that. About my about my app, there are including the sections. So it would have the relationship. So their friends and family would go to the apps and they have to access about the relationships of their survivors, of their friends, like their concerned friends. Like the relationship is including toxic relationship, red flag relationship, and danger assessment for that. So if we know about the relationships, the AI or the system, the app would screen and score and talk to you about the health strategies. I mean that if you have different relationship, you would get different health strategies, right? If this app would be tailored for each person. So it would be like the health strategies, including communication skills, including safety plannings, including kind of like things that they have been. For example, like if you are students, if you get pregnant, if your friends, your husband have guns, have knife, and have kind of thing, it would show you about different health strategies. And also about resources. Resources including the NGOs, resources, the government hotlines, and the legal and lawyers hotline for that. And my learning that I would like to educate them about what is the healthy relationship should be, what is the consent should be. And also the chatbot, they also ask the chatbot for that. So the chatbot, I have been adapting for that. If you are interested in, I would love to share more. Probably next time about that. So I created the chatbot under the AI and make sure that that they would answer correctly and empathetic for that. Yeah.
All right,
Thank
thank
you.
Thank you. It's very interesting, Achan, for your application because you were using AI to your application. And the last question, Achan Tiparat, is there a relationship or is there any relationship between intimate partner violence during pregnancy and postpartum depression? Could you explain more based on your experience, Achan?
Yeah, exactly. You know what? When I talk about, I talk more like they have strong predictors that if you have experience during pregnancy, why we know that? Because they visit our antenatal care, right? That we accept and we know that about that. It's for 30, 40 weeks, right? For during that period. But for before that, before pregnancy and after pregnant, it would be stronger predictor as well that they would have experience before and they would have experience after that. Yeah, for the postpartum period, they would have, for my research and the study we showed up, they would have experience about depressions. And they still have experience about violence from their partners because it would have trauma time. I can tell that if women stay at home and take care of children alone, right, they would have not supportive resources for that. And yeah, and for sure, it is a strong predictors for have experience after postpartum, especially about mental health consequences.
Okay, Achan. Or is there any cases, Achan, as you mentioned before, that if the pregnant woman also can get the IPV and also getting the depression? And is there any cases in Thailand when the pregnant woman get the depression and then they will harm by herself or maybe suicide? Is there any cases in Thailand, Achan?
Absolutely, yeah, absolutely, for sure. They are vulnerable population for
Alright.
that.
Okay, and how
Yeah.
about the rule of midwifery or nursing in there? What is the rule?
The rules,
Yeah.
right? Okay, it's very good question and excellent for that. So the roles for that, we should, I think the role would be screening for sure. The screening role and try to recognize on that. So the second rule is support women and make sure that you have the referral system for women for that. Because if you're a midwife, right, for this case, it would be complicated case. It would take for a while, for a long time, that you would say like, oh, Zantiparat, I have a lot of pregnant women for that. I don't have time for that. Yeah, for sure, in Thailand as well. But you have to set the referral system that, okay, if you already screen and they have opportunity to have the chance, okay, let have the reference, like a referral to people who are responsible for this, and go to the psychiatrists, doctors to do this. So I think screening role and referral role can would do that, and preventing role, that would be another one that we would talk more about that too. Yeah.
Okay, thank you, Dr. Tiparat, for your thoughtful answer and valuable discussion today. And we can highlight some key points from Dr. Tiparat explanation today. Intimate partner violence during pregnancy is a serious public health issue with profound physical, psychological, and social consequences for both the mother and unborn child. The evidence across multiple countries shows that IPV is common, often begins early in woman's life, and may worsen or continue during pregnancy. The impact include trauma, miscarriage, preterm birth, depression, anxiety, and increased risk of suicide. Pregnancy does not protect women from violence. Rather, vulnerabilities such as young age, low social economic resources, unintended pregnancy, and reproductive coercion heighten the risk. Effective screening that Achan Tiparat said before and compassionate healthcare responses are therefore crucial. Healthcare providers play a vital role in identifying IPV, offering empathetic support, enhancing safety, and connecting women to needed service. Approaches such as live, listen, inquiry, validate, enhance safety, support, empower providers to respond appropriately. Community resources, emergency intervention, and culturally adapted tools such as the WeSafe application that Achan Tiparat explained before, strengthen safety and resilience for survivors. Protecting pregnant women from IPV requires awareness, coordinated care, and strong commitment to compassionate. Evidence-based intervention ensuring safety is not only a clinical responsibility, but a moral one. Thank you again to Dr. Tiparat Please give another round of applause to Dr. Tiparat Utmuangpai.
Thank you so much. Thank you.
Yeah. Ladies and gentlemen, our second speaker is Ms. Masta Hutasoit Eskep Nurse MKep PhD candidate from the Nursing Department, Faculty of Health, UNJAYA. Please welcome Ms. Masta. Okay, I would like to invite Ms. Masta, but let me introduce Ms. Masta Hutasoit. Mrs. Masta Hutasoit Eskepnes MK PhD candidate is a nursing lecturer at the Faculty of Health Science, Universitas Jenderal Ahmad Yani Yogyakarta, with nearly 2 decades of experience in nursing education and clinical practice. She holds a bachelor in nursing from the Adventist University of Indonesia and a master's in nursing from Gajah Mada University, and is currently pursuing her PhD at Lincoln University College, Malaysia, specializing in pediatric and maternal nursing. And also she has published over 25 journals articles and authored 8 nursing books between 2023 and 2025, covering topics such as stunting prevention, maternal health, and adolescent behavior. Her extensive experience and dedication to nursing education continue to inspire both students and professionals. Ms. Masta will share her presentation on optimizing the role of parents to prevent sexual abuse in children with intellectual disabilities. To Ms. Masta Hutasoit, time is yours.
Thank you for moderator. Hello everyone. Good morning. Thank you for staying with us here in Zoom room in the second day. Today I would like to share about the interesting topic with the title Optimizing the Role of Parents to Prevent Sexual Abuse in Children with Intellectual Disabilities. We just listened to a presentation about violence during pregnancy in Thailand, which is quite similar to my topic. The difference is my topic focus on prevention sexual abuse in children with intellectual disability. I'm Masta Hutasoit from Department of Child and Maternal Nursing, Universitas Jenderal Ahmad Yani, Yogyakarta. The cases of sexual abuse, or SA, among children, including with intellectual disabilities, or CID, continue to increase every year. Indonesia is even described as being in a state of emergency regarding sexual abuse. Children with intellectual disability, or CID, are particularly vulnerable to sexual abuse due to cognitive limitation, communication difficulties, and reduced social awareness. SA in CID is often difficult to recognize and report due to their limited knowledge and ability to understand or express what they experience. What is the meaning children with intellectual disability, or CID? CID is a disability characterized by significant limitation in both intellectual functioning and adaptive behavior, which cover many everyday social and practical skills that originate before the age of 18, according to the American Association of Intellectual and Developmental Disability, or AIDD 2023. CID is a disorder with onset during the developmental period that includes both intellectual and adaptive functioning deficit on conceptual, social, and practical domains, according to the Diagnostic and Statistical Manual of Mental Disorder, DSM-5. The conceptual domain includes skills in language, reading, writing, matching, and reasoning. The social domain refers to empathy, social judgment, interpersonal, and communication skill. The practical domain center of self-management in area such as personal care, job responsibilities, and organizing school and work tasks. What is the meaning sexual abuse in CID? Sexual abuse in CID is an act of degrading, harassing, and attacking a person's body or reproductive function. Such acts may include physical or verbal sexual harassment, forced sexual intercourse, exploitation, or sexual torture. Sexual abuse is the act of involving a person in sexual activities that are not to his or her wishes, involving adults and children, which is usually for stimulation or sexual satisfaction of the abuser. And sexual abuse can occur anywhere. The prevalence of sexual abuse in CID is relatively high, with approximately 1 in 5 girls and 1 in 10 boys affected. In Indonesia, the exact number of cases remains unclear due to underreporting. In 2023, sexual abuse against children, including those with intellectual disabilities, accounting for the large proportion of cases, totaling more than 2,000 cases or 24.8%, according to Ministry of Women's Empowerment and Child Protection 2023. CID are at risk of being sexual abuse 2 to 8 times more than children without ID. Global data of SA in ID was 32.9%. CID in Indonesia around 18.3 per 1,000 children, equivalent to 1.83%. Indonesia, 2023, total sexual abuse in children, including CID, ranked highest with including CID rank with total more than 2,000 cases. Cases of sexual abuse in CID often go undisclosed due to the communication barriers, limited language skill, a lack of trust in child report, and parents' failure to identify signs of abuse. From this slide, we can see the classification of children with intellectual disability according to American Association on Intellectual Developmental Disability, or AADS 2021 and APA 20 and 22. We can see the 4 classification of CID. Number 1 is mild ID with IQ 50 to 69. The children in the classification can learn basic academic skill to the elementary level, often appears normal in early childhood. The communication skill, children with mild ID can communicate verbally using simple sentences, understand and participate in everyday conversation, can read and write with guidance. The independence in daily living, or ADL, generally the children are independent in self-care, needs minimal support for complex tasks. The children with mild ID need periodic supervision, support in social and vocational skill. Number 2 is moderate ID with IQ 35 to 49. The children in the classification with noticeable developmental delay can learn functional communication and basic life skills. They can use simple spoken language for basic needs, limited vocabulary, understand short and concrete instruction, but struggles with abstract concept. They can perform most basic ADL, like feeding, dressing, hygiene, with occasional assistance. Need consistent guidance for safety and community activities. The children in the classification need daily monitoring, simple vocation training, structure, and predictable environment. The number 3 is severe ID with IQ 20 to 34. The children in this classification have a significant developmental delay, often accompanied by physical or neurological impairment. The communication skill of children with severe ID have very limited speech, only 1 to 2 words or short phrases, relies most non-verbal communication like gestures, facial expression, or visual aids. Independence in daily living, or ADL, requires extensive support for nearly all ADLs, can be trained to perform simple tasks like self-feeding under close supervision and repetition. The type of support needed full-time caregiver support, speech and occupational therapy, augmentative or visual communication tools. The number 4 is profound ID. They have IQ below 20. The children in this classification have extremely limited intellectual and adaptive functioning, often accompanied by severe physical or sensory impairment. The communication of profound ID has minimal or no verbal at all, no verbal communication at all. Respond to basic social cues, tone of voice, facial expression, express need through basic emotional or physical. They completely dependent on caregiver for all daily living activities, feeding, bathing, dressing, mobility, and requires caregiver or parents 24-hour supervision. Continuous intensive care sensory stimulation program, multidisciplinary therapy, and medical support. This is the graphic. The rate of child victim of sexual violence per 10,000 children. We can see from this graph, so the incidence of sexual abuse across 38 provinces in Indonesia. This is the most recent 2025 data from Ministry of Women, Empowerment and Child Protection. There are 3 provinces with the highest number of sexual abuse cases: Central Java with almost 2,000 cases, Central Java and East Java with nearly 1,500 cases, and Yogyakarta with more than 400 cases. Okay, this is the number of cases by location in Indonesia and the form of violence most experienced by the victim in sexual abuse. The graph on the right side, we can see the number of cases by location in Indonesia, showing that the most common location where incidents occur in the household, with more than 50,000 cases. The graph on the left side, we can see the most frequently form of violence against children is sexual violence or sexual abuse with more than 11,000 cases, followed by physical violence with over 9,000 cases and psychological violence with more than 8,000 cases. The conclusion from these 2 graphs in Indonesia, sexual violence most frequently occurs in household, and the most prevalent form of violence against children is sexual violence. This is the graph of the victim based on the age. From the graph that show that the Indonesia in 2025, the victims of violence are most commonly found in the age group of 13 to 70 years with more than 9,000 cases, followed by the age group of 6 to 12 years with more than 6,000 cases. Why are children with intellectual disability, CID, more vulnerable to sexual abuse? We can see number 1 is because they have cognitive limitation, because they have communication barriers. Number 3, high dependence on adult, lack of sexual education, and social stigma and stereotype. The vulnerability factors, the summarize of vulnerability factor of CID in experiencing sexual abuse consists of 3 factors. Number 1 is individual factors, number 2 is family and environmental factor, and number 3 is social and relational factor. Individual factor because the children with intellectual disability have cognitive and communication deficit. Children with IDs often have impairment in cognitive abilities, social development, emotion regulation, and communication skills, both expressive and receptive. This deficit can hinder their ability to understand, recognize, and report abuse, making them more susceptible to victimization. The ability, number 2 is perception and reporting of abuse. The ability of children with IDs to perceive and report abuse is often compromised, which can delay disclosure and intervention, further exacerbating their risk. Number 2 is factor of family and environmental, because the family vulnerability factors such as low parental education level, economic problem, yearly marriage of parents, broken families, and parental substance abuse or violence significantly increase the risk of sexual abuse in children with IDs. Number 2 is out-of-home care. Children with IDs in out-of-home care setting are at a higher risk of sexual abuse compared to those in regular out-of-home care and the general population. This is due to the lack of adequate supervision and support in these environments. Number 3 is social and relational factor. Because the children with IDs often depend heavily on caregiver or parents for daily needs, which can create opportunities for abuse, especially when caregivers are the perpetrators. Number 2 is social isolation. Social isolation and restrictive routines can increase the risk of abuse, and these children may have fewer opportunities to seek help or disclose abuse. What is the characteristic of perpetrators? The perpetrators of sexual abuse in children are usually individuals who are familiar to the child and are within the child's immediate environment, such as family member, caregivers, peers, or teachers. This trust can be exploited to commit abuse. And other individuals with IDs, there is a notable risk of abuse from other individuals with IDs, possibly due to the shared environment and similar deficit in social and cognitive skill. The data from Ministry of Women Empowerment and Child Protection Indonesia in 2025, the perpetrator based on the relationship, you can see the graph. The graph shows us the perpetrators based on their relationship with CID. The majority of perpetrators are from the child's immediate social environment, with more than 4,000 cases involving friends or peers, boyfriend and girlfriend. In addition, a large number of perpetrators come from within the family itself, including parents or relatives. Why can the perpetrators be from the child's immediate social environment? Because they are aware that the child with ID are weak, easier to control, and less likely to report what happened. The perpetrators believe that the victim's limitation will hinder them from disclosing or reporting the sexual violence they have experienced. How can caregivers or parents recognize signs of sexual abuse in CID? Parents play a crucial role in identifying signs of sexual abuse in CID. Recognizing the sign can be challenging due to the communication barriers and unique vulnerabilities of the children. Here are the key indicators and consideration based on the profile abstract. Number 1 is behavioral signs and physical sign. The parents must be vigilant and attentive to any behavioral changes in children with intellectual disability. There are 2 signs, behavioral sign and physical sign. This may manifest a significant regression. Regression is a loss of acquired skill. For example, bedwetting, emotional shift, unexplained withdrawal, aggression, or anxiety. Social behavior, socialized behavior, age inappropriate sexual knowledge or action, sleep disturbances, nightmares, or significant changes in sleep pattern. Developmental loss, decline in verbal, social, or academic skills. And the children maybe have the behavioral signs, self-harm, emergence of sexual injuries behavior. Any persistent unexplained change from the child baseline is a critical warning sign. Number 2 is from physical sign. If parent or caregiver notice any physical changes, they may indicate sexual abuse. It is important to seek medical help immediately. Physical signs can sometimes be subtle, but they should never be ignored. Example, may the children have redness, swelling, bruise, frequent pain when sitting or walking, or repeated urinary tract infection. The symptom may suggest that something has happened to the child's body, even if the child is unable to express it verbally. When such signs appear, do not wait, do not assume, and do not try to handle the situation alone. The next step is consult to the healthcare professional as soon as possible. Why parents are the primary pillar in preventing sexual abuse against children with intellectual disabilities? The parents hold the most critical role in preventing sexual abuse due to several fundamental reasons. Number one is because the parent is constant presence and strongest emotional bond. The parents are the closest and most consistent figures in the child life. They understand behavioral patterns, nonverbal expression, and even the smallest changes in the child that might go undetected by others. The emotional bond built since birth create a foundation of trust that cannot be replaced by any other party. Number two, because the parents have a unique understanding of the child communication method. Parents are typically skilled translators who can understand nonverbal cues, body movement, or specific sounds that signal the child's discomfort. They are most capable of adapting safety education according to the child's level of understanding. Number three, the parents have greatest access and supervision to the children. Parents have the most access to the child's daily life at home, during care, and in social interactions. They can implement consistent supervision and build a physical, safe environment on ongoing basis. Number four is highest stake and commitment to the child well-being. Unlike other professional or caregiver, parental commitment is permanent and unconditional. As we know, the love of the parents is unconditional. They have the strongest motivation to protect their child. Important decisions regarding the child's safety rest entirely in the hands of the parents. And five, acting as filters and supervisors. Parents serve that the primary gatekeeper who select and supervise caregiver, therapist, teacher, and social environment that will interact with the child. They can implement protection system and teach consistent, safely strategies across all settings. The number six, most sensitive detective or changes. Even subtle behavioral changes such as nightmares, loss of appetite, or sudden fears are most likely to be first detected by parents who know their child intimately. There are three pillars framework to parental empowerment or to strengthen parental role. Number one is adaptive sexual and safety education. Provide parents with simple, accessible learning materials about sexuality and safety for children with ID. Number two is open communication and as a responsive environment. Help parents learn how to talk about sensitive topics using language their children will understand. Number three is proactive supervision and advocacy. School, health professionals, and communities should work together to create consistent message about protection. Support empowerment parent needs emotional support from peers, professionals, and community programs. We can see the pillar one, the adaptive sexuality and safety education. The goal of the pillar one is build body literacy and safety concept. And practical strategy that parents can do to their children is teach body awareness and privacy. To protect CID, it is important to provide body safety education in ways that are simple, direct, and respectful. Use clear and correct terms. Teach anatomical name, for example, penis, vagina, to eliminate confusion and empower clear reporting. When children know the correct name of their body part, they are more likely to communicate clearly if something inappropriate happens. Identify private parts, use visual aids like diagram or dolls to show body part covered by a swimsuit. Visual teaching is especially helpful for children who learn better through picture or physical demonstrate rather than verbal explanation alone. And then establish boundaries, teach that no one shall touch or look at their private part except for health and hygiene reasons. For example, doctor with parent present, caregivers during bathing, teaching the boundaries is not about creating fear, it is about building confidence and safety. This pillar focuses on providing children with intellectual disability with tailored knowledge about their body, boundaries, and safety using methods and match their learning. Introduce consent and autonomy. Practice saying no. Role-playing scenario where the child can refuse unwanted touch even from unfamiliar people. Use simple phrases. Teach the phrases like stop, I don't like that, or this is my body, because the children is boss of her body. Respect their choices, encourage autonomy in non-sensitive contexts, letting them choose who to hug to build confidence, and differentiate between safe and unsafe touch. Safe touch, hugs from family, high fives, handshakes. Unsafe touch, touching private part, hitting, or any touch that feels scary or confusing. Unwanted touch, even safe touching, can be unwanted. Teach that it's okay to say no. The pillar 2 is open communication and responsive environment. The goal of this pillar is to parents serve a communicator, safe harbors, and environmental architects to build a child-first line of defense. The practical strategy is to open and adaptive communication, teach the body safety, use correct anatomical, and responsive and trusting environment, be askable parents, react calmly to question and disclosure to build unwavering trust. Conduct safety audits, assess environmental, something like school therapies for their child protection policies. Build a safety network, ensure all the caregivers know and follow the same safety rules. The core goal is to create a foundation of trust and honor where the child feels safe to speak up and the parents is equipped to listen and respond. The pillar 3 is proactive supervision and advocacy from the parents. Yeah? The goal of the pillar 3 is the parents are the managers of the children safety network. The practical strategy is to proactive supervision, creating a layer of safety. Safety rules establish open door policies during the care and private session. Reduce opportunities, avoid one-on-one situation in closed room with unfamiliar adult. Build a network, create a safety team of trusted adults who know the rules. Advocacy being the primary voice. Questionnaire situation, ask school therapy center about their child protection policies and staff training. Speak up, interfere as a bystander if the situation or interaction seem inappropriate, and document, keep record of behavioral changes and safety-related communication. Why this pillar is critical? Because the IDRs often exclude from sexual education, leaving them unaware of absent and unable to protect themselves. The pillar equip them with knowledge to recognize inappropriate behavior, language to report abuse clearly, and confidence to assert their boundaries. Goal of this pillar is to transport vulnerability into empowerment through the compassionate practical education. There are several major barriers to provide sexual education for children with intellectual disability, especially in Indonesia. There is a myth that CIDs are asexual or always like young children. Because of this belief, their need to understand their bodies or personal boundaries is often ignored. The sexuality is still considered a taboo topic in many cultures, especially when related to disability. Parent and teacher may avoid the topic because they feel uncomfortable or worry about being judged. There is also a lack of appropriate teaching materials and training. Many parents and educators lack access to visual, simple, and adaptable resources, leaving them unsure about how to teach it. The communication differences are another challenge. Traditional teaching method may not work well, so the approach needs to be adjusted to the child ability. In the education system, sexual education is often not included or prioritized in individuals' learning plans. Some adults also worry that teaching about sexuality will cause inappropriate behavior, even though research shows the opposite. There is also the belief that the child will not understand, so education is never attempted. Not top of that, many parents are already busy with daily care demands, leaving limited time and energy. We can see the role of the healthcare professional overcoming barriers to sex education for CID. As a trusted figures, healthcare professional are vital in breaking down barriers to essential sex education for children with intellectual disability. The barriers category consists on societal attitude, practical and systemic, and parental consent. The healthcare something like nurse or doctors or midwifery can educate and reframe, debunk the asexuality myth with fact about human development. Frame the conversation about safety, health, and right, not just sex. Use empowering language. Shift the focus from vulnerability to skills building for autonomy and safety. Practical system provide tools and training. Train parents in adaptive method, social story, visual aid, and create and distribute simple, accessible resources. And then advocate within system, empower parents to request sex education in children, individualized education program, repair family to specialize in support organization. And parental consent, they validate, reassured, acknowledge parental anxiety, explain that education reduce risk and prevent problematic behaviors. Empower with small step, counter my child won't understand by demonstrating simple routine-based lesson during bathing or dressing. The conclusion of this topic, the parents are the most crucial and consistent protectors, leveraging their unique understanding on their child communication and behavior. Empowering parents means empowering children. When the parents have the knowledge, skill, and confidence to protect their children, they become the strongest barriers against sexual abuse. The final message of this topic, by empowering parents as primary educators and advocates, we can build effective multi-layer protection system that safeguard children with intellectual disabilities and ensure their right to safe dignity development. This is the references, and thank you for your attention. And the time I give back to the moderator.
All right, thank you very much, Ms. Mata. Please give applause to Ms. Mata. Mrs. Mata. Yeah. Thank you. Your presentation is very clearly, Mrs. Mata. All right. Our speakers before, Hasanti Parat, she said that or her presentation about the violence against women, including pregnant women, and then remains serious and complex issues with significant impact on the physical and mental health for women or pregnant women, and also it can be as well as on the fetus and child health development. And Mrs. Masta,
Yes.
yeah, Mrs. Masta
Sir
topic
Ano,
also, yeah, related with,
is related
with
quite
Achanti Parat, yeah, that's right. And then Ms. Masta said that the equally important issues of violence against children with special needs, yeah,
Yes,
is it right?
special need.
And then who are more vulnerable than another children, health
Yes.
children with without special needs. And then it's about vulnerable due to communication limitation and also dependency of caregivers, and also persistent social stigma. And maybe in this chat room or Zoom meeting, we have any question to Mrs. Masta? Is there any question? Okay. There is question to Mrs. Masta.
Okay.
How can cultural norms and family beliefs in Indonesia influence the acceptance or rejection of sexual education for CID? Could you answer this question, Mrs.
Okay,
Masta?
thank you to Miss Unita from from semester 5
Yeah.
ya. Okay, this is the good question. Okay, how can cultural norm and family beliefs in Indonesia influence the acceptance or rejection of sexual education for CID? Okay, thank you for the question. I will try to answer. In many Indonesian families, sexuality is seen as something private, even taboo. When it comes to children, especially children with intellectual disabilities, the topics becomes even more sensitive. Some parents worry that discussing sexual matter will open the child curiosity or encourage inappropriate behavior. However, what we see in practice is the opposite. Silence creates vulnerability. When parents avoid teaching body safety, the child has no framework to understand what is the right or wrong touch. Therefore, they gain acceptance. We must reframe sexual education not as sexualization, yeah, but life skill for safety. Just like teaching children how to cross the street, this is safety, yeah, safety education. When parents understand that the goal is protection, not promoting sexuality, they are more open to participating.
Okay, so it's like a polite education to
Yeah,
our
polite,
children about their protection.
Yeah, sex
and
education
their-
not
yeah.
only to talking about the sexualization.
Yeah.
Yeah.
Not
but-
only the anatomy,
Yeah, not
but the children should protect their
body.
body.
Yeah. Okay.
Okay, is there any question?
But this is the life skill for safety. Yeah.
Okay. And the next question is, what happens if you experience social isolation? What happens if you have experienced social isolation maybe? What should you do to avoid getting too caught up in it?
What happens if you experience social isolation? What shall you do avoid getting to
Caught up.
catch up
on-
in? How to raise public awareness about sexual violence against people with disability?
Yeah.
The question from?
From Angel Subliana.
Okay. Okay. The children with intellectual disability, usually the parent teaching sexual education to children, especially intellectual disability, is not about teaching sexuality. The children with intellectual disability have cognitive and communication limitation. The education must simple, visual, and consistent. We can use picture, maybe dolls or daily routines to explain which body part. If the children in public awareness about sexual violence, we must to teach the children how to say no or how to catch, to avoid confusion and help them to communicate if something inappropriate happen.
Maybe we can to move to another question, yeah. Okay, so what is the next question? What is the indicator, yeah? Okay, what is the indicator?
What is the indicator can be used to evaluate whether sexual education program for CID are effective. Okay, the effectiveness of sexual education program is seen not only in what children know, but in how they act. For example, a successful program result in the child being able to identify private part, differentiate safe and unsafe touch, and express refusal, such as saying stop or pulling away when uncomfortable. If the children have the experience unsafe, the children must say stop or pulling away when uncomfortable. Parents should also report the feeling more confident and less anxious when guiding their child. In schools or care setting, we shall see clearer safety rules, improved supervision, and consistent communication among staff. So evaluation is multi-layer. Child ability, parent readiness, and environmental responsibility. When all three improve, it means the program is truly working. So the parent must continue to educate, and repetition is important things to the children with intellectual disability.
Okay, thank you, Ms. Masta, for your answer for these questions.
Okay, this question is
So-
enough. I think it's enough.
All right. Thank you very much, Ms. Mata, for your answering this question. And then, ladies and gentlemen, from the Mrs. Masta explained to us about the violence to the someone or children with special needs, we can highlight some key points. The children with the intellectual disabilities are among the most vulnerable groups to sexual abuse, due to communication barriers and then dependencies on caregivers and limited essentials and irreplaceable role, in prevention by strengthening parental knowledge and communication skills and proactive supervision from the parent. Is it right, Mrs. Masta? And families can also transform vulnerable into protection, empowerment, and resilience through adaptive sexuality education that you mentioned before, open communication, and strongly advocacy. Parents become the child's safety environment to the children, and the strongest defense against abuse. Empower parents build empowered children and an empowered community. Is it right, Mrs. Masta? Okay, thank you very much, Ms. Masta, for your
You're
time.
welcome.
Yeah, see you in the next UNICHS.
Thank you.
Yeah. Okay, this concludes our. Oh, please give applause to Mrs. Masta. Yeah, thank you very much. All right, this concludes our topic session at the 4th UNICHS 2025. As today's moderator, I certainly appreciate your active participation and attention throughout this conference. Now, I would like to hand the session back to Ms. Lola, our Master of Ceremony. The floor is yours. Thank you.
Thank you so much to our moderator and speakers for the insightful session. And now we truly appreciate your valuable knowledge shared with us. And next, we will process with poster presentation part 3. And please enjoy the creative work presented by our participants.
Welcome to the final session of the poster competition at the UNJAYA International Conference of Health Science 2025. In this closing part, we proudly showcase the final set of posters, highlighting innovation, collaboration, and academic excellence in the field of health science. Let us begin our last series of presentations. Implementation of cold compress therapy to reduce pain intensity in post-operative closed fracture patient in Alamanda Room 2 RSUD Sleman by Nuriana Arumaisha, Retno Sumiarini, and Prativi from Universitas Jenderal Ahmad Yani, Yogyakarta. Effectiveness Telenursing for Heart Failure on Quality of Life, a Systematic Review and Meta-Analysis by Vidya Anissa Firdaus, Iin Inaya, Cecep Eli Kosasi, Dedi Supriyadi, and Murtiningsih from Universitas Jenderal Ahmad Yani, Cimahi, and Pajajaran University. Case Study: Implementation of 20-degree foot elevation technique on pain reduction in lower limb fracture patient at RSUD Panembahan Senopati, Bantul by Iis Putriningsih, Novita Nirmalasari, and Heni Widayanti from Universitas Jenderal Ahmad Yani, Yogyakarta. How prepared and aware are students toward disaster risks? By Novita Nirmalasari, Rizky Wahyu Hidayati, and Ika Wuri Winahyusari from Universitas Jenderal Ahmad Yani, Yogyakarta. The relationship between family support and stress level of female prisoners at Class 1B Women's Penitentiary in Wonosari, Yogyakarta by Citra Amelia Dewi and Suwarno from Universitas Jenderal Ahmad Yani, Yogyakarta. The effectiveness of red onion extract on headless mortality by Herlina Ineke Surjane Wuno, Nurjana Jenode, Windy M.V. Wariki, Oswaldo Nayuan, and Hiskia Rumampuk from Samratulangi University. Nutritional composition analysis of dried red dragon fruit as a highly nutritious food by Dwi Susanti, Suwarno, and Enda Puji Astuti from Universitas Jenderal Ahmad Yani, Yogyakarta. Family Caregiver-Based Stroke Rehabilitation Assistant, its effect on caregiver burden and quality of life by Miftahul Darussalam, Oni Setiani, Untung Sujianto, and Mateus Sakundarnoadi from Universitas Jenderal Ahmad Yani, Yogyakarta and Diponegoro University. Implementation of early mobilization intervention to reduce pain intensity in post-appendectomy patient at Sleman Regional General Hospital by Devi Fatima, Retno Sumiarini, and Prativi from Universitas Jenderal Ahmad Yani, Yogyakarta. Case Study: Application of Progressive Muscle Relaxation Therapy in Hypertensive Patient to Reduce Blood Pressure by Nurul Hidayah, Retno Sumiarini, and Fitri Setiawati from Universitas Jenderal Ahmad Yani, Yogyakarta.
The relationship between self-management and non-communicable disease in the Panda 1 Bantul Community Health Center area by Ika Adi Cynthia and Ngatuyatu Rohmani from Universitas Jenderal Ahmad Yani, Yogyakarta. Efficiency and data quality of health worker after the implementation of C-Penting by Amri Wulandari, Berlina Putriantis, Murti Krismianti, Adhan Soleh, and Saumi Fijriah from Politeknik Kesehatan Karya Husada Yogyakarta and Universitas Jenderal Ahmad Yani, Yogyakarta. Psychoeducation on self-efficacy and relationship closeness among mothers of toddler, a quasi-experimental study by Dewi Utari, Agus Warseno, and Dian Puspitasari from Universitas Jenderal Ahmad Yani, Yogyakarta. Organoleptic test of moringa noodle soup among nursing students at Universitas Jenderal Ahmad Yani, Yogyakarta by Suwarno, Novran Putra Pratama, and Murwani Eko Astuti from Universitas Jenderal Ahmad Yani, Yogyakarta. That concludes the poster competition exhibition of the 4th UNJAYA International Conference of Health Science 2025. We sincerely thank all participants for the meaningful contribution and commitment to advancing health research. May this conference continue to inspire collaboration, innovation, and excellence in global health community. Thank you and congratulations to all participants of the 4th UNICHS 2025.
Selamat datang di Politeknik Kesehatan Karya Husada Yogyakarta. Politeknik Kesehatan Karya Husada Yogyakarta memiliki 7 program studi yang terdiri dari D3 Keperawatan dengan akreditasi unggul, D3 Kebidanan dengan akreditasi sangat baik, D4 Promosi Kesehatan dengan akreditasi sangat baik, D4 Kebidanan terakreditasi baik, D4 Keperawatan terakreditasi baik, Profesi Bidan terakreditasi baik serta Profesi Nurse terakreditasi baik. Dan kami telah berpengalaman menghasilkan tenaga profesional kesehatan lebih dari 35 tahun. Sebagai upaya mencapai visi perguruan tinggi yaitu menjadi perguruan tinggi vokasi yang unggul dan berorientasi global tahun 2039, maka lulusan dibekali dengan keterampilan sesuai dengan keunggulan pada masing-masing program studi. Untuk menghasilkan lulusan yang profesional dan siap kerja, pada pembelajaran praktik dilengkapi dengan sarana laboratorium dan teaching factory. Pada program studi D3 Keperawatan, D4 Keperawatan dan Profesi Nurse, pembelajaran praktik dilengkapi dengan fasilitas laboratorium dasar dan kegawat daruratan serta pelatihan bersertifikat BTCLS. Pada program studi D3 Kebidanan, D4 Kebidanan dan Profesi Bidan, pembelajaran praktik dilengkapi dengan fasilitas kebidanan dasar, kebidanan komplementer dan teaching factory serta pelatihan bersertifikat Mom and Baby Treatment. Sedangkan pada program studi D4 Promosi Kesehatan dilengkapi pula dengan studio desain grafis, fotografi videografi, multimedia, bengkel produksi serta pelatihan bersertifikat pelatihan media. Prestasi yang diraih oleh Politeknik Kesehatan Karya Husada Yogyakarta antara lain mendapatkan hibah dari Kemendikbudristek melalui program kompetitif Fun Vokasi selama 3 tahun berturut-turut dan program Matching Fun Vokasi, serta menjadi juara 1 kampus terbaik dalam pelaporan PD Dikti, kategori akademi, politeknik dan akademi komunitas dari seluruh perguruan tinggi swasta di wilayah LL Dikti wilayah 5 Yogyakarta. Peserta didik akan dibimbing oleh dosen yang profesional dan ahli di bidang kesehatan, dengan lebih dari 70% telah tersertifikasi dosen profesional. Adapun prospek kerja bagi lulusan, baik di luar negeri maupun di dalam negeri. Di luar negeri diantaranya di Rumah Sakit Taiwan, Jepang dan Arab Saudi. Sedangkan di dalam negeri diantaranya Rumah Sakit, Klinik Pratama, Klinik Bersalin, Puskesmas, Dinas Kesehatan, Klinik Mom and Baby Spa, Praktik Mandiri Bidan, LSM, Basarnas dan berwirausaha. Lebih dari 10.000 alumni telah membuktikan diri menjadi tenaga medis yang profesional dan sukses berkarir di bidang kesehatan. Politeknik Kesehatan Karya Husada Yogyakarta hadir sebagai kampus vokasi kesehatan yang siap mengantarkan Anda untuk meraih kesuksesan menjadi tenaga bidan, perawat, promotor kesehatan yang terampil dan profesional.
Mari bergabung bersama kami di Politeknik Kesehatan Karya Husada Yogyakarta. Tangguh menginspirasi.
Politeknik Karya Husada Yogyakarta.
Tangguh menginspirasi.
Okay, that was the last video of our poster presentation and also the profile of our co-host, Politeknik Kesehatan Karya Husada Yogyakarta. And we will now have our lunch and prayer break. Also, participants in Zoom may log out and rejoin before 12:30. Continue with the oral presentation sessions. For our presenter, please you can directly enter your respective breakout rooms. As assigned, our committee will assist if you experience any technical difficulties. Also, for improvement, please fill the evaluation form. Your feedback is really valuable to us, and the committee already shared in the text box. And for now, we have a wonderful lunch. Thank you, and see you after the break.
Recording stopped. Recording in progress.
Indonesia dengan populasi 270 juta menjadikan Indonesia negara yang besar. Peningkatan populasi seiring sejalan dengan angka morbiditas yang tinggi. Disinilah tenaga kesehatan sangat dibutuhkan untuk membantu pembangunan kesehatan bangsa. Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta berkomitmen dalam menghasilkan lulusan yang unggul dan berdaya juang tinggi.
Misi Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta menjadi fakultas kesehatan yang unggul dan terdepan di bidang kesehatan, serta mewarisi nilai-nilai kejuangan Jenderal Ahmad Yani.
Visi ini dibuktikan dengan 2 prodi telah terakreditasi unggul pada tahun 2022 dan 2023. Visi Fakultas Kesehatan secara relevan memayungi visi seluruh prodi di lingkungan Fakultas Kesehatan.
Visi Prodi Keperawatan dan Profesi Nurse, Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta, yaitu menghasilkan lulusan yang unggul dan terdepan dalam bidang pelayanan kesehatan primer di tingkat nasional, serta mewarisi nilai-nilai kejuangan Jenderal Ahmad Yani.
Visi ini dijabarkan dalam 6 misi yang meliputi aspek pendidikan, penelitian, pengabdian kepada masyarakat, kerjasama, perwujudan good university governance, dan internalisasi nilai-nilai kejuangan Jenderal Ahmad Yani. Untuk menjalankan misi ini, Prodi Keperawatan dan Profesi Nurse didukung oleh SDM berkualitas yang merupakan lulusan S2 dan S3 baik dari dalam maupun luar negeri. Dosen secara aktif menjalankan Tridharma perguruan tinggi, aktif dalam organisasi profesi dan keilmuan, serta kegiatan ilmiah di tingkat nasional maupun internasional.
penguasaan dengan kurikulum terkini berdasarkan pada kurikulum perguruan tinggi dan asosiasi institusi pendidikan profesi, dengan tentunya mengedepankan keunggulan prodi yaitu pelayanan kesehatan primer.
Berbagai metode pembelajaran diimplementasikan untuk mencapai keunggulan seperti diskusi tutorial, case-based learning, metode demonstrasi, metode diskusi kelas, simulasi, metode praktikum, metode project-based learning. Laboratorium yang digunakan oleh Prodi Keperawatan memiliki peralatan yang lengkap untuk menunjang ketercapaian dari kompetensi-kompetensi perawat dan nurse. Ruang laboratorium terdiri atas keperawatan dasar, anak, maternitas, medikal bedah, kegawat daruratan dan kritis, jiwa, keluarga, gerontik dan komunitas, laboratorium biomedik, laboratorium farmakologi, laboratorium komputer dan bahasa. Sedangkan laboratorium yang menunjang visi misi yaitu Laboratorium Perawatan Kesehatan Primer atau PSC, Perawatan Kesehatan Kerja atau K3, dan Perawatan Kesehatan Sekolah. Selama mengikuti proses pembelajaran, Prodi membebaskan mahasiswa untuk mengikuti kegiatan non-akademik seperti himpunan mahasiswa dan berbagai unit kegiatan kemahasiswaan. Mahasiswa juga mendapatkan fasilitas yang memadai untuk pembelajaran dan pengembangan diri, meliputi perpustakaan yang dilengkapi dengan koleksi buku, e-book, jurnal, dan berbasis e-library, fasilitas ruang ujian CBT, dan ruang ujian OSCE yang semua dilengkapi dengan loker. Fasilitas lain seperti asrama, kantin mahasiswa, tempat parkir, ruang hima dan UKM, lapangan olahraga, dan minimarket.
Memasuki program profesi, visi program studi tercermin melalui penambahan stase primary healthcare atau PHC dan pelatihan-pelatihan yang menunjang keunggulan program studi.
Kegiatan ini meliputi penambahan materi perawatan kesehatan primer, dan pelatihan keselamatan kesehatan kerja.
Bekerja sama dengan mitra yang kredibel, menjadikan lulusan kami memiliki pengalaman yang mumpuni dan membantu dalam peningkatan kualitas pendidikan, penelitian, dan pengabdian kepada masyarakat.
Dibimbing oleh dosen yang berkualitas dan profesional di bidang keperawatan, menjadikan mahasiswa siap berkompetisi di dunia kerja.
Puskesmas Kalasan. Pada kesempatan ini menyampaikan bahwa Puskesmas Kalasan telah bekerjasama dengan Prodi Keperawatan dan Profesi Nurse sejak tahun 2019 dengan wujud implementasi yaitu terbentuknya Klinik UNJAYA dengan program edukasi dan konseling pasien. Tidak hanya dalam bidang pendidikan, namun kami juga dilibatkan dalam pengabdian dan penelitian. Terima kasih.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Dr. Kurnia Putrawardana dari bagian Health HSSE PT Kilang Pertamina Internasional R5 Balikpapan. Saya sangat mengapresiasi salah satu lulusan terbaik dari Universitas Jenderal Ahmad Yani Yogyakarta, yaitu Saudara Abdul Hafiz, atas kinerjanya selama bekerja sama bersama kami. Hal ini terlihat dari kinerja Saudara Abdul Hafiz yang sangat baik, bertanggung jawab, komunikatif, dan bisa diandalkan. Inilah modal utama dalam bekerja sama bersama tim demi mencapai tujuan bersama. Terima kasih Universitas Jenderal Ahmad Yani Yogyakarta. Assalamualaikum warahmatullahi
wabarakatuh. Saya Abdul Hafiz, alumni program studi keperawatan dan pendidikan profesi nurse Universitas Jenderal Ahmad Yani Yogyakarta. Belajar di program studi keperawatan Universitas Jenderal Ahmad Yani Yogyakarta dengan bidang keunggulannya primary healthcare mampu mengantarkan saya bekerja di bagian kesehatan kerja PT Kilang Pertamina International Refinery Unit 5 Balikpapan yang merupakan salah satu perusahaan badan usaha milik negara. Saya bangga menjadi lulusan Universitas Jenderal Ahmad Yani Yogyakarta.
Nama saya Ari Saiful Bahri, saya ada alumni Prodi Keperawatan dan Profesi Nurse UNJAYA. Proses pembelajaran di prodi keperawatan dengan berbagai metode diskusi sangat mengasah kemampuan saya untuk berpikir kritis, independen, dan decision making yang baik. Ditambah dengan nilai kejuangan Jenderal Ahmad Yani membuat saya yakin dan berani untuk berjuang di luar negeri.
Warahmatullahi wabarakatuh. Haji Master, watashi no namae wa Erika Agustin Wulandari, Erika to moshimasu, yoroshiku onegai shimasu. Saya merupakan alumni Universitas Jenderal Ahmad Yani Yogyakarta, prodi S1 Keperawatan dan Profesinis. Dengan kondisi lab yang sangat memadai sehingga mampu membuat kita untuk menjadi terdepan, sehingga kita mampu bersaing di kancah internasional. Terima kasih, semangat untuk semuanya. Ganbate kudasai. Jayo, arigatou gozaimashita. Otsukare sama deshita. Sayonara. Wassalamualaikum warahmatullahi wabarakatuh.
Nasionalis, patriotik, heroik.
Assalamualaikum warahmatullahi wabarakatuh. Universitas Jenderal Ahmad Yani Yogyakarta merupakan lembaga pendidikan yang diselenggarakan oleh Yayasan Kartika Eka Paksi di bawah binaan TNI Angkatan Darat dengan visi menjadi universitas yang unggul dan terdepan di tingkat nasional serta mewarisi nilai-nilai perjuangan Jenderal Ahmad Yani. Universitas Jenderal Ahmad Yani Yogyakarta atau dikenal pula sebagai UNJAYA memiliki sasanti Aditya Mahatma Daksa yang bermakna senantiasa menghasilkan lulusan yang pandai, bijaksana, berjiwa besar, cakap dan ahli, serta UNJAYA berkomitmen mempersiapkan para Ahmad Yani muda yang nasionalis, patriotik, dan heroik.
Fakultas Teknik dan Teknologi Informasi Universitas Jenderal Ahmad Yani Yogyakarta saat ini mengelola 4 program studi, yaitu Prodi Sistem Informasi S1, Prodi Informatika S1, Prodi Teknologi Informasi S1, dan Prodi Teknik Industri S1.
Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta saat ini mengelola 8 program studi, yakni Prodi Pendidikan Profesinis, Prodi Keperawatan S1, Prodi Kebidanan S1, Prodi Kebidanan D3, Prodi Pendidikan Profesi Bidan,
dan Prodi Psikologi S1 yang kesemuanya diarahkan untuk menjawab tuntutan perkembangan ilmu dan teknologi di era ekonomi digital.
sebuah kebanggaan bagi kami dapat mendidik dan mempersiapkan para Ahmad Yani muda sebagai generasi penerus kejayaan bangsa Indonesia.
Satu. He.
Cek.
Cek.
Masuk. Cek. Iya, Bu. Ladies and gentlemen, praise to be to God, all oral presentation sessions have been successfully completed. We would like to express our appreciation to all for your excellent efforts and inspiring research contribution. And now we have come to one of the best awaited moments, the announcement of the best presenter for oral and poster presentation. The committee has carefully reviewed and assessed all presentation, and it's time to recognize those who have shown outstanding performance. And I would like to announce the best poster winners based on the category. And for the best creative design, the winner we have Vidya Anissa Firdaus. Congratulations to Vidya Anissa Firdaus. And the first runner-up of creative poster design categories we have Iis Purtiningsih. Congratulations to Iis Purtiningsih. And the second category we have for the best artistic visual creativity. The best winner we have Azara Nurian Sinta. Congratulations to Azara Nurian Sinta. And first runner-up of artistic visual creativity foster generation categories is Susanti. And next, we move to the best scientific content category. We have the best winner is Mrs. Triana Irmayanti. Congratulations to sorry for I'm sorry, I will correcting my pronunciation. For the second categories, for the best artistic visual creativity, we have Azara Nurian Sinta. Congratulations for Azara Nurian Sinta. And the first runner-up of artistic visual creativity foster categories, we have Mrs. Susanti. And the third of the best category, scientific content. The winner we have Trisia Irmayanti. For congratulations to Mrs. Trisia Irmayanti. And the first runner-up of scientific content poster categories, we have Mr. Donatus Corbianus Sadipudin. Congratulations to Donatus Corbianus Sadipudin. And now we move to the oral presenter for the best oral presenter. For best oral presenter for innovation technology category is Dr. Eka Diah Kartiningrum. Congratulations to Dr. Eka Diah Kartiningrum. And the second winner for innovation technology category is Amri Wulandari. Congratulations to Mrs. Amri Wulandari. And the next, for the best oral presenter for scientific research methodology category is Sirti Mardiana Trisinta. Congratulations to Mrs. Sirli Mardiana Trisinta. And the second winner for scientific research methodology is Mrs. Luti Pratiwi. Congratulations to Mrs. Luti Pratiwi. And next, for the best student participant for oral presentation, we have Mr. Kaka Abdurrahman Karim. Congratulations to Kaka Abdurrahman Karim. And the best oral presenter for runner-up is Miss Zulfiana Maharini. Congratulations to Zulfiana Maharini. And the second runner-up is Lola Arista. And the last one, I want to announce the best oral presenter for general category. And for the best oral presenter for general participant, we have Mrs. Rina Fitriana Rahmawati. And for the first runner-up is Dr. Made Kurni Widyastuti. Congratulations to Dr. Made Kurni Widyastuti. And for the second runner-up, we have Mrs. Nuraida and Suwarsi. Oh, sorry. We have Lutfi Nuraida. And congratulations to Miss Lutfi Nuraida. And the second runner-up also Mrs. Suwarsi. And once again, congratulations to all the winners. Ladies and gentlemen, we have now reached the end of our two-day international conference. On behalf of the organizing committee, we express our sincere gratitude to all keynote speakers, moderator, presenter, and participants for your activity, contribution, and enthusiasm. We hope this conference has inspired meaningful collaboration and innovation in advancing primary healthcare practices. Thank you very much for being part of the 4th UNICS 2025. See you again to our next conference. Have a wonderful evening and goodbye to all of us.
Thank you so much. Congratulations to all the committee and participants.